how we can prevent infection and diagnose infection, treat infection. So we have eminent panelists here. We have the neonatologists from all over the country. Bijan is working at SSKM Hospital, Calcutta. Neeraj is at AIMS, Jodhpur. Manas is working in a private setup in Bhubaneswar, and Dr. Rita is from Assam. So we have neonatologists here who have been working in core neonatology, and we'll try to see how they manage babies with infection. What do we have in future? We have seen Ashish telling us that we don't have antibiotics. So can we diagnose infection early? Can we prevent infection? So how do we manage if a baby has infection? So what are the other methods we can use? And what methods can we be used to treat infections effectively is what we're going to see. And we'll go through 3 case scenarios. The first case, I think, can we switch this off? Ye light off. We have here a late preterm, 35-week, 2.4 kg baby, born to a mother with gestational hypertension. Mother had GDM, so she was an insulin. The baby was born cesarean for static weight for the last 2 weeks. There is no history of urinary tract infection. There is no history of fever, cough, cold, or PPR in the mother. The baby was born vigorous at birth, Abgas were 8 and 8, not requiring resuscitation. The baby started having respiratory distress from birth, was shifted to the NICU on TPs. Now, what happened is this baby started to have progressive respiratory distress in the first 4 hours. So we have a baby who is otherwise didn't have any complication except for mother having GDM on insulin, starts having distress early and keeps on increasing. The heart rate is 163, respiratory rate is 64, the baby had recessions, and SAS score is 6/10. Blood pressures were normal, there was no organomegaly, reduced air entry, there was no murmur, the baby was active and alert, tone was normal. The possibilities by the treating team was respiratory distress syndrome, transient tachypnea of newborn, and pneumonia. They thought they started the baby on IV fluids, CPAP, and antibiotic. They've used amikacin as a first line here, and they sent for chest X-ray. They got some baseline investigations like total count was 20,000 per mm3, neutrophils were 68%, micro-ESR was 7 mm per hour, band pulse were 2%, and platelets were 2.21. I'm sure most of you see clinical scenarios like this. And this is X-ray. They were expecting RDS. They were expecting TTNB, but X-ray is showing low to normal volume of lungs. There is increased vascularity, but what you can see is there is haziness here, there is haziness here, and there is haziness there. So clinically they thought of TTNB or RDS, but X-ray wise they are looking it is, and it's a progressive distress. X-ray wise they are seeing some haziness in different parts of the lung. Now the questions to the panelists here. Bijan, is it early onset sepsis?
So, although initial probable diagnosis were TTNB and RDS, but the clinical investigations and the examination doesn't fit to that. So, definitely we have to consider early onset sepsis in this case because X-ray was suggesting haziness on the right upper zone, and it was not a low volume lung, and the other parameters were not in accordance with TTNB or RDS. So, in this kind of scenario, I think we should keep.
So what we are saying is, if you have distress and you can't explain the distress by RDS or by TTNB, because the course is not explaining TTNB, so that's why we want to think it may be infection. Neeraj, can you tell us how we can exclude sepsis in this baby? Can we say that this is not sepsis? What can we do to say that this is not sepsis, this is just a distress which may require a supportive care?
When we talk of early onset sepsis, in this patient, though as has been mentioned that clinical possibilities were RDS or TTN, but unfortunately the X-ray findings are not going hand in hand. So, in such a situation where X-rays are failing more of features of pneumonia but not of RDS or TTN, then of course one would say that okay, considering this course, one should start antibiotics. But issue is, this is a very common scenario. If we don't give antibiotics, we will lose check if the patient actually has sepsis. And if we give antibiotics and the patient doesn't have sepsis, then it will have its own consequences. So the issue is that can we do something to do this? Yes, people have, there are basic 2 approach for that. One is you go for some investigations And second approach is people have try to look for various risk factors from the maternal details and looking at the clinical course of the baby. And they have tried to quantify the risk, and they have given some cutoffs that if the risk is more than this, you should start antibiotics. If the risk is between such and such, you should just take the investigations and observe the child, and if it is below this, you should. So basically people have tried to generate some scoring system. One of the scoring systems which have been published in 2014 was where what they have done is that they have looked at the maternal risk factors for early onset sepsis, like the duration of rupture of membranes, what was the highest temperature of the mother, and in Western setup we know that there is group yeast streptococcus is a major problem. So accounting for that, and from that baseline incidence and these risk factors, they divided that okay, if the risk is less than 0.64 per thousand live births, between 0.54 to 1.54 and beyond that. So based on this, then they followed these babies in first 12 hours. This study was primarily done for late preterm terms, like something which we are dealing here. Our baby is 35 weeks. So this study has been also done in the same population beyond 34 weeks, which means late preterm terms. And then they try to see the risk factors in the baby, like in first 12 hours, whether the baby is symptomatic or asymptomatic. If the baby is asymptomatic, they have put it as clinically well. If the baby is sick in form of any respiratory distress requiring oxygen or any ventilated support, or baby has features of shock, or baby is showing some CNS features in form of encephalopathy or seizures, so that they have categorized as sick. So something in between the two, they have put it as equivocal, which means basically patient has some abnormalities in these vitals like tachycardia, tachypnea, mild distress not requiring oxygen, or hypothermia, which is lasting for at least more than 2 hours. So based on that, they have come up with the various scoring, and from there they have tried to put all these into calculator, and then they come out that okay, if this is the score, we'll take cultures and start antibiotics if it is so. So the basic purpose of doing this exercise is to reduce the unnecessary exposure of antibiotics, simultaneously not missing any case of early onset sepsis, because if you miss, then it will have its own repercussions. If you look at the NICE guidelines given by the UK people, they have tried to simplify this whole algorithm. They have just given red flag indicators. So they have mentioned that if there is a single red flag indicator, which they have again tried to look into the two aspects, maternal risk factors and neonatal risk factors. So if the mother is getting any antibiotic before 24 hours, means within 24 hours of the labor or during that labor process or after 24 hours of the delivery, if the mother is getting antibiotic because of some suspected or proven infection, it is a red flag indicator that if the baby is born, even if the baby is asymptomatic, you have to start antibiotics. Or some neonatal indicators they have tried to give, suppose even if the baby has, let's say, a term baby going on to ventilator support, invasive ventilation, or baby going into shock. So all these they have again classified and given some scoring systems, indicators which will help us in doing this.
So this baby, so any baby at birth we need to evaluate in two aspects. One is, are there any risk factors for infection or not? So the risk factors for infection, among all the things which Neeraj has suggested, the one of the most important thing is whether mother has received antibiotics or not. If the mother has received antibiotics and it is more than 4 to 24 hours, then there is a very high chance that baby may have an underlying infection. So risk factors is one way of looking at it, because if the risk factors are there, baby is more likely to have infection. The second thing is you have to club with the risk factors to the clinical scenario in the first few hours. The well baby, equivocal, or a clinically symptomatic baby. So if you combine these two, Neeraj, our baby fits into which of this category? You have the risk scoring based on the maternal risk factor, you have the clinical way of looking at. So in this matrix, the baby fits into which part?
So if you see this algorithm, our patient had clinical illness. So
he has clinical illness,
which means this patient should be
treated empirically, he should be given antibiotics. So although the risk of having infection from the maternal risk factor is less than 0.65 per thousand live births, using the risk scoring, because this baby, the mother did not receive antibiotics, there was no PPR, there was no maternal fever, there was no UTS. So based on the maternal risk factor, he is not at risk, but he is a clinically symptomatic baby, so this baby needs an infection treatment although we know that many times we might be overdoing it. So the guidelines say that you can do one method is by risk scoring and by clinical picture. Manas, any other methods are there? Any tests are there for us to say that, okay, this is not infection? Can we do some tests?
Basically, all the basic investigation like CDC and CRP, these are done in early in the life. So if I look at early onset sepsis, I should have a repeat testing of these parameters at a lateral part of life, maybe around 8 to 10 hours after this test. And if those are positive, this gives an idea that it could be infection. And not to mention that when we have started antibiotics, rightly they have started antibiotics as amikacin according to the unit policy, and they must have taken a blood culture which will again corroborate or refute the possibility of infection.
Dr. Rita, what do we use this test for? Is it for ruling an infection or ruling? Because clinically you have already decided to start antibiotics. Now why you want to do this test? CBP or CRP or other newer tests. Why do you want to do the test?
This baby actually has clinical sickness, so it will be just to rule out other causes.
So all the tests are meant not for ruling in sepsis, they are meant for ruling out sepsis. If this baby clinically fits into septicemia because there is X-ray finding, there is clinical distress which the baby had. So you have to start antibiotic, that is one issue. But if the baby's counts are normal, at 6 to 8 hours after birth, if CRP is negative and if procalcitone is negative, then you can say that very unlikely the baby has a septicemia. He could have a pneumonia but he doesn't have a blood infection. So then you are more confident of stopping the antibiotics early for this baby. You don't have to go further because this baby will say that if CRP is negative, if counts are normal, if your procalcitone is negative, you can safely stop the antibiotics, giving antibiotics for 5 to 7 days in a case of pneumonia like this. So antibiotics are going to help us to rule out sepsis and not to rule in sepsis. Even if CRP is positive, you would have continued antibiotics. If procalcitone is positive, you would have continued antibiotics. So starting antibiotic is not based on the CRP or procalcitone, but when to stop antibiotics, whether we have to prolong antibiotics is going to be based on these tests. So Dr. Rita, what is the role of procalcitone? So there is a lot of hype on procalcitone, or is it real or is it a myth that procalcitone helps us in curing sepsis?
For early onset sepsis, actually procalcitone doesn't have much sensitivity or specificity because for many other reasons there can be rise of procalcitone level and also it is age-specific.
Yeah.
But for late onset sepsis, it may be useful.
So for early onset sepsis, what Dr. Rita is saying is procalcitone is not a very specific marker because procalcitone can go up in the first few hours because of delivery itself, section, stress, asphyxia, PPR. So many things can increase the levels of procalcitone. And if you have to see what procalcitone, how it correlates, you have to have an age cutoff. So you need to have an nomogram at what age, what is the level, and then compare it with the level and see whether baby can be having an associated inflammation or not. All these are inflammatory markers and not infection markers. They don't have specificity. So that is why you can't rule in. They will all help you to rule out sepsis. CRP, again, repeated CRPs, if they are negative, then you can say there is no infection. But CRP is positive and then doing again is not going to help you to rule in sepsis. So the point which you want to make from the first case scenario is, definitely when you can't explain an illness because of what you think as TTN or RDS, you have to think of infection, start antibiotics, but you need to ensure that to decrease the duration, you have to do the workup to rule out septicemia, that is blood culture associated, blood associated bacteremia. So if we have said that we are going to start so we are going to justify antibiotics in this scenario. So is there a need for blood culture in this situation? Rita?
In this case, when we have decided to start with antibiotic, definitely we need to do sampling for blood culture before we start antibiotics.
So whenever we are starting antibiotics, we have to send blood culture. There is no going away. But how can we get a good blood culture?
To get a good blood culture, we need to follow the procedure of sampling properly. So we need to wash our hands properly. The 6 steps should be followed. Gloves should be worn, and then a tray which contains the requisite things like betadine as well as the spirit and the gauze pieces which are needed. The sterile ones should be there. There should be one needle which is sterile, another to take the sample, a syringe attached to the needle should be there. then the area from where, the vein from where we'll be taking the sample, that area has to be cleaned properly. So for that, we'll clean the area of around 5 centimeter size around the venipuncture site, and that has to be cleaned by betadine and spirit. The betadine has to be in contact with the skin for at least 1 minute so that it is effective. And then we puncture the vein with a needle, and then from the hub we take the sample. And this sample has to be of adequate volume, so it has to be around 1 ml, and it has to be inserted into the culture bottle, which the diaphragm of which is cleaned with the spirit, and then the content of the culture should also be around 10 to 20 ml, so not more than that, because otherwise the blood would be getting diluted and the lysins which are there inside can inhibit the growth. Then while storing this sample, it has to be stored in room temperatures till we send it to the laboratory, or it can be stored in an incubator with a temperature of 36 to 37 degrees centigrade.
So if some of you are wondering why our blood cultures are always coming negative when the baby is clinically having signs of sepsis, it's because we don't follow the rules. And as Dr. Rita said, there are a few important things. Volume. 1 ml of blood is must. And your broth has to be a pediatric one or a newborn related where your blood broth ratio should not be more than 1:10. And the second thing is, never take your sample from indwelling catheters and arterial lines. You have to take from a fresh venipuncture, or you're putting a new cannula, you take the blood from that. And the other thing what Dr. Rita said is asepsis at the time of taking sample. So these 3 things you have to follow to get your cultures properly. Now the other things which comes to our mind is, now we always look about recent things, new things. So Dr. Bijan, if at 4 hours, if I want to rule out sepsis, because we said counts you have to wait for 6 to 8 hours. We said CRP you have to wait at least 24 hours. Procalcitonin again 4 to 6 hours you have to wait before you say that there is no infection. So are there any other methods to rule in or rule out sepsis very early, at within 4 hours?
Yes, sir. Actually, whatever the biomarkers we have already discussed, this usually become positive after 6 or 12 hours. But before that, some newer biomarkers are available, and this can be talked in time frame. Suppose we want to rule out sepsis within 12 hours of life. So, what are the biomarkers that can be done? One of the some promising biomarkers that is available, the IL-6, IL-8, tumor necrosis factor alpha, and neutrophil CD64. These 4 biomarkers, these become positive and around TAT time around 1.5 to 6 hours. So if this can be done and it becomes positive within 6 hours. But the problem remains, all the unit, they may not have the facility to all these investigations. And if you want to send this investigation outside, then again it will take more than 6 to 12 hours. But these are the promising biomarkers which can be done early, within 12 hours. From 12 to 24 hours, there are other biomarkers that have already been discussed. So, and it is said that if these newer biomarkers like IL-6, IL-8, and if it is combined with neutrophil CD64, then the sensitivity specificity increases. So these are the promise, but the facility for this investigation must be available in the FDA. Otherwise, it will need another more than 6 hours time for the investigation to be available.
So the biomarkers are something which can help you to rule out sepsis very early, because the process of sepsis, if you look at this is the process of sepsis. The microbe enters, it creates some particles called pathogen-associated molecular protein, and this pathogen molecular protein will affect different type of systems, either blood or lymphatic system, or the vascular system like endothelial, epithelial, adipose tissue, or the complement and coagulation. So once these cells are affected, the microbe is affecting these cells, then they release different markers. The complement releases different markers, the coagulation system gets different markers, you get different markers from the endothelial cells, you get markers from epithelial cells, and you get markers from the lymphocytes, the granulocytes, and the neutrophils. So you can use these markers for diagnosis of sepsis. You have plenty of markers here. And then once these markers affect the tissues, then you get procalcitonin or CRP and other things. So if you want to pick up early, you have facilities, you can use some of the biomarkers. But again, remember, they don't rule in sepsis, they only help you to rule out sepsis. So this is how they are divided. In the first few hours, you have IL-6, IL-10, and tumor necrosis alpha. In the next 3 to 12 hours period, you have procalcitonin, and after 12 hours, you have the CRP coming up. So they can be divided into early marker, mid marker, and late markers. So within 24 hours, you can rule out sepsis by any one of this marker. But as Bijon said, these are very costly, not available at all places. Procalcitonin again in the present situation is very costly. So we still depend on CRP. So we need to wait to 12 to 24 hours before we can say it is not infection. Now the next thing is if the blood culture is sterile. This baby's blood culture is sterile, and by day 3 with the supportive care and antibiotic, baby has become asymptomatic. Manas, would you stop antibiotic for this baby now? Because we started thinking of infection. There was X-ray which was plus minus infection, and cultures came sterile, and our screen also was almost negative. So should we continue antibiotic? Should we stop antibiotic?
Here definitely we are treating a case of pneumonia, and probably there is no septicemia or sepsis in this baby. And if my clinical course is comfortable, by second or third day my baby has improved, I will prefer giving antibiotic for 5 to 7 days.
So the current consensus is if you're treating pneumonia, you treat for 5 to 7 days. But since this baby is asymptomatic by 3rd day, by 5th day you can stop the antibiotics. There is no need for you to prolong the antibiotics just because you started it. Your clinical course is better, screen is negative, cultures are sterile, by 5th day you can stop the antibiotics in this baby. Manas, while we are on this topic, is there a role of very short course of antibiotic for screen positive or CRP positive or counts positive sepsis? Culture negative, screen positive sepsis. Any role of very short course?
Those sepsis are called probable sepsis, and in those cases people have studied short course antibiotics, and they have compared with 7 days course of antibiotics and short course maybe around 48 hours, and they have seen no big difference. So short course antibiotic can be tried, and one should take clinical course into consideration and decide regarding the duration, exact duration of antibiotics in those children. But short course antibiotic is possible, but the experience is very small.
Yeah.
There is 1 or 2 study which is available, which has looked into this short course of antibiotic versus the standard long course antibiotics. So we need to practice long course of antibiotic till you generate good amount of data on safety and experience on the short course of antibiotics. So till that time, I will prefer giving the standard 5 to 7 days of antibiotics.
So what Manas is saying that yes, there is some evidence coming up, but the evidence is not strong enough for recommending very short course. But I think time has come for all of us to do some large multi-center trials and show that yes, we can decrease the duration of antibiotics. We don't have problems by cutting short the duration of antibiotics. What Lot has done from the PJ study, where they have compared a very short course. As soon as the baby becomes asymptomatic, the cultures came sterile, they stopped the antibiotics, all the screen was positive. So if any of one of you thinking of screen positive sepsis for continuing antibiotics, look at this study and try to see in your own setup, do some study and see if you can give very short course of antibiotics. Now we come to the second case scenario where exactly similar situation where there is no risk factor for infection. The baby, apart from having respiratory distress which is progressive, within first few hours baby also has off color, tachycardia, prolonged CFT, cold peripheries. His CPAP, his requirement is going up, his pressure requirement has gone up from 5 to 6, FO2 requirement has gone up from 50 to 70%. He was given 1 dose of surfactant 4 hours, but baby still has worsening distress. A echo was done which did not show any heart disease. Chest X-ray was showing typical of RDS. And CRP was done at 8 hours, CPP was done at 8 hours, which is showing 36,000. Neutrophils with 68%, band form with 2%, CRP negative and platelets with 3.4 lakhs. Now this is X-ray which is showing normal or less inflation. There are some air bronchograms, there is some reticular granularity. Now the question here is this early onset sepsis? Neeraj, do you think this is early onset?
Looking at the case, it looks like that we were dealing with RDS, but unfortunately, there are few pointers in this case which are taking away from that. One is that this patient, despite of giving surfactant, the course is slightly odd. So looking at the typical cases of routine clinical course of RDS which we see. Second is, this patient is showing features of hemodynamic instability. So because of these two reasons, and it is well documented that when we have X-ray findings sometimes it is very difficult to differentiate on chest X-ray whether it is an RDS picture or it is because of the streptococcal infection, which also gives a very similar kind of picture. So because of this atypical course of, even despite of being surfactant and patient showing features of hemodynamic instability, I would take culture and tend to start antibiotics in this case.
So you are thinking it is septicemia because the distress, although the RDS is not progressing like RDS, the rest you should have explained the resolution, but it is worsening and there is a hemodynamic instability. Can we rule out? Can we do some tests to rule out the infection in this case?
Again, the strategy I think again remains same, which we discussed, that one need to go for those basic investigations including your CBCs, IT ratios and your CRPs, but again those will be helping in ruling out rather than ruling in. And even again if you try to consider this patient, even if you fit into those scoring systems which we discussed, again it qualifies for antibiotics.
Suppose I got the test done at 8 hours, it is instead of 34,000 it is just 20,000, CRP is negative and CRP 12 to 24 also is negative. So what do you want to do then? You have started antibiotics thinking it is early onset sepsis, but your screen parameters have repeatedly come negative, your counts are normal, so what do you want to do then?
I would like, considering the clinical course of this child, I would look at the blood cultures and the subsequent course of the BP and looking at patient, so I would tend to continue the antibiotics.
So one is you have to think of infection, but if the screen is coming repeatedly negative, your counts are normal, think beyond sepsis. It could be a case of just say obstructed TAPVC or a heart disease which may not be picked up on a routine echo. So you need to get involved the cardiologist and ask them to specifically look for, am I dealing with something different? Or it could be a group B which may take a little longer time to grow. So always when things are not working in the way you think, please involve other people to ensure that you're not missing out on something else. Can we justify use of antibiotic in this, Rita?
Yes, we can justify use of antibiotics in this scenario because the child has shock and we are suspecting sepsis.
So if you see what we are doing is, both the situations, there was no risk factors, but when you have unexplained signs and symptoms, please start antibiotics. Early antibiotics will save the baby rather than waiting for the baby to deteriorate and then start multiple courses of antibiotics. So starting antibiotics in a clinically symptomatic baby, there is nothing you can do, you have to start. But once you get the screen negative or culture negative, stop early and that is how you will help. That is the best antibiotic stewardship you can have. Is there a need for blood culture in this situation?
Again, definitely because we are starting antibiotic, so we will be taking a blood culture.
So I think please do not depend on anything else but blood culture for diagnosing infection in babies. Is there any role for additional investigations like CSF and urine in this baby?
In this patient, we would like to do CSF, but because this baby is sick at this point of time, maybe we can defer it. But for urine, we would not go for any urine culture because if anything grows on that would be a part of the systemic infection.
So I think less than 1 week, even if the clients of sepsis are there is no need for you to do a urine examination because most of the time UTI in the first 1 week is a consequence of bacteremia. So it's a hematogenous spread. So you treat infection, UTI is going to decrease. But after 1 week, any infection you think of, you also have to do urinary culture or urinary examination. CSF, if the symptomatically sick baby, you can wait. What antibiotic to start? The $1 million question. Manas.
Basically, in the previous case, people have started amikacin. We have no objection because they have good experience on that because it must be covering almost 70 to 80% of their bacteria that they are getting in early onset sepsis. So I think to decide on which antibiotics we should have our own experience to guide what kind of antibiotics we should give a broad spectrum of coverage initially. But when you get a culture positivity, I can narrow down to the single antibiotics which will cover the particular bacteria. So initial will be a broad spectrum antibiotic when I do not know the type of bacteria and its sensitivity pattern. But subsequently, if my culture comes positive, I can narrow down on the antibiotics.
So what we are saying is, we can't decide what antibiotic you have to do in your unit. You have to decide your antibiotic. You have to grow microbes from your babies. You need to know the sensitivity pattern, and then only you can decide what empirical antibiotic you can start in your unit. You may get outborn babies, you may get inborn babies, but you should know your bugs. before you can think of what is antibiotic which you can start in your unit. We cannot say amikacin, we can't say piperacin tazobactam, we can't say polystyrene. So whichever is working for your unit, that is the one which you have to start based on your previous culture reports. This may be improved with IV fluids, CPAP, 2 doses of surfactant, piperacin tazobactam, dopamine and dobutamine over the next 48 hours. The blood culture which grew on day 3, Klebsiella pneumoniae, sensitive to ceftriaxone, amikacin and piperacin tazobactam. Luckily the baby was on piperacin tazobactam and the Klebsiella is sensitive to that. After getting the blood culture, an LP was done. An LP showing 29 cells, protein of 120, sugar of 35, against a blood sugar of 63, and the CSF culture is sterile. Now, Dr. Rita, can you tell us how do we interpret this CSF when you are given antibiotic for 3 days and then you do the LP?
This baby who has already received antibiotic, the CSF shows that culture is sterile, so this is expected. And the cell count is 29 per cubic millimeter, which is higher than normal. So if it is more than 20, you would be taking it as positive. Protein is also on the higher side, but sugar, although it is less than almost 50% of the blood sugar, but still this may not be an indication that there is meningitis, the hyperglycemia part, because many times sick babies have hyperglycemia because of stress or dextrose infusion. But if it is less than 20, you would be taking that as an indicator of meningitis. But overall, because of the pleocytosis, I would take it as meningitis.
Yeah, I think any clinically symptomatic baby, if your culture is positive, cells more than 10 or cells more than 20 are definitely you have to think of meningitis. So if you think of meningitis, this is considered to be a biochemical meningitis, should be treated like meningitis. Because we cannot ignore even one child with meningitis getting incomplete treatment. Now, which antibiotic do you want to choose? Now, Neeraj. So you want to continue with piperacin tazobactam because 3 days baby is asymptomatic, or because you are labeling meningitis, do you want to convert piptaz to piperacin tazobactam to ceftriaxone?
See, in this patient, if we see the patient has responded to your piperacin tazobactam which we started, but unfortunately the CSF is showing meningitis, and we know that the penetration of piperacin tazobactam for meningitis is not good. Though we have some evidence to suggest that okay, the meninges are inflamed, then the penetration of piperacin tazobactam can be there, but since it's not still standard, so I would switch over to the cefotaxime in the anti-meningitic dose and continue with that cefotaxime.
So if you want to switch over to ceftriaxone, so what you understand is although piperacin tazobactam works for acute phase of meningitis, once the meningitis resolves, you want to continue the course, then it may not be effective to decrease total load of bacteria from the blood and CSF. So we want to use a drug which penetrates the CSF better. But how long you want to treat? You want to consider the 3 days of antibiotic, or you want to don't consider that? And how long? In the case of meningitis, gram negative, how long you want to continue?
See, actually, whatever guidelines we have, they are all consensus based. There is no evidence to say that in culture positive for how long, in meningitis how long. Conventionally, what we are following is that for any meningitis, we are continuing for 3 weeks. For culture positive sepsis, it is around 10 to 14 days. And previously, which we discussed for probability is around 5 to 7 days. But
so I think 5 to 7 days for screen positive, 10 to 14 days for culture positive, and 21 days for meningitis is our routine thinking. Now this, we don't know where these numbers have come from. There is only consensus and guidelines saying that this, but we don't know really. Nobody has tried to check a short course versus a long course versus an extra long course. So we don't know where these numbers have come from. So till that point, we have to continue with whatever as the guidelines. But Manas, is there any role for short course treatment in culture positive sepsis? So I want to stop the antibiotic at 7 days. Is it okay?
Again, there are some studies where there is no meningitis, only culture positive sepsis. They have tried 7 days versus 14 days of antibiotics, and they have found failures in specifically if it is a staph sepsis, the failure is quite high. So I think if it is staphylococcus positivity, then I will prefer giving antibiotics for 14 days and rather than 7 days.
So this baby has become asymptomatic by 3rd day. This baby is asymptomatic by 3rd, 4th day. So you want to continue how long is it? This is Klebsiella.
Basically, if the patient's clinical course carries a lot of meaning, patient has responded by 3rd day, I will prefer giving antibiotics for maybe 10 days.
So what you are saying is if there was no meningitis, if there was no meningitis, we would have been satisfied in continuing antibiotics maybe 10 days because the guideline says 10 to 14 days. So we want to be on the lower side of normal. But this study, I think all of us should look at, because there are two studies now which have come from India. One is from Rajasthan, the other is from PGI. Both have shown that 7 days is as good as 14 days, with the caveat that if you have a staph sepsis, you have to continue for 2 weeks. But most of the gram-negative culture positive sepsis, there is no problem because the failure rates in gram-negative like Klebsiella is exactly same whether you give 2 weeks course or a 1 week course. And these babies were followed up at least a month after stopping the antibiotics to see for any other recrudescence or other infections which might happen in these babies. So there is some evidence, but we need to generate again more evidence on short course antibiotics because that is way forward for decreasing our duration of antibiotics and antibiotic resistance. So we have one more case before we close. This is a late onset sepsis. Now this baby is a 33 weeker, 1.88 kg. Was day 16 of life. He presents with poor feeding and they reduced activity for 2 days. Baby was admitted in a local NICU for first 7 days. And that time he was given IV fluids, antibiotics and oxygen. We don't know what antibiotic this baby has got in the first 7 days. He was an EBM and formula at the time of discharge. And from 1.88 at the time of discharge from that hospital, recorded weight is 1.46. At admission, the baby is sick looking, lethargic, he has cold peripheries, his mild heart rate is 152, respiratory is 52, there are some retractions. Weight from 1.46 has come to 1.6, definitely not what we expect. CFT was prolonged, there was no murmur. The baby had jaundice, the liver was palpable, it was soft, there was no spleen or pallor. AF was level, tone and activity were decreased, and blood sugar at admission is 32 milligrams. So the baby's course was like this. He was started on 10% dextrose, normal saline bolus and IV fluids. They started him on piperacillin, tazobactam, vancomycin and fluconazole. Now, is this late onset sepsis, Dr. Rita? You have a baby who had an NICU course, remains well and comes back to the hospital. Is it late onset sepsis?
Yeah, I'll consider late onset sepsis as a probable diagnosis here.
So if it is late onset, is it hospital-acquired infection or is it a community-acquired infection?
This baby was already in the hospital and was given IV fluid antibiotics for almost 7 days, after which the baby was discharged. So probably this was a hospital-acquired infection.
So Manas or Meera, do you agree with that baby is discharged on 7th day, comes back on 16th day with signs of infection. Do you want to consider this hospital-acquired infection or it is a late onset? Community-acquired. Manas.
So most likely it will be a hospital-acquired infection because the child was not doing well in the first admission. If you see the wet gain, there is severe weight loss and the baby was not doing well. So I will still consider it as a hospital-acquired sepsis.
So, Neeraj?
I would slightly differ considering that there is a gap of 7 days and patient has been treated, though we don't know what antibiotics and what doses the patient has received, and most of the time these patients do manifest in next 72 to 96 hours. So in this situation, rather it will be very difficult to pinpoint that is it really community acquired or hospital acquired.
So I think what we have come to the conclusion, although the definition says that if a baby has clinical signs and symptoms of infection, within 2 days after discharge, you consider as hospital-acquired infection. But here, we know that baby required hospitalization. He was given antibiotic for 7 days and was discharged with a weight which was very significantly low. Comes back after 1 week. So we really don't know whether it is incomplete sepsis treated or something else which was there for this baby, which has led to infection in this baby. So what would be the risk factors for this baby if it were hospital-acquired late onset sepsis?
It's mostly the IV fluid which has been given because that is an invasive procedure for the baby. Then antibiotics again has been shown that prolonged use of antibiotic can also lead to late onset sepsis in the initial period. And if he had been given some formula feed, that can be also again another risk.
So, as you see here, low birth weight, hospital admission, antibiotic or formula are definitely risk factors for infection. And these are the risk factors for fungal infection. So in this scenario, they thought of sepsis, fungal sepsis, UTI, hypoglycemia, hyponatremia, and the clinical features were there. So should we rule in or rule out of sepsis in this baby? Neeraj? You have a clinical symptoms, you have hospitalization, now we have to rule in or rule out sepsis?
See, I think in this patient, there is no denial that we are not dealing with sepsis. So here, there is no point in going for sepsis screen. Here you have to start antibiotics. Patient had already features of shock, patient was hypoglycemic, there was deterioration, and the first possibility was sepsis. Though you do tend to get hemograms to look at platelet count, whether that has some therapeutic treatment or not, management or not. So here the supportive or the basic investigation needs to be done, but it's not a part of sepsis screen. Here you have to upfront start antibiotics and see the course.
One thing is, okay, you will think of infection. Do you want to think of anything else? Because baby was asymptomatic at discharge, comes back after 10 days or 8 to 10 days. You want to think of anything? He also has jaundice. There is hepatomegaly. So, do you want to think anything else, or you just want to think it is only infection?
See, the first possibility I will still consider, if you look epidemiologically, the kind of iteration with the previous course, I will still keep sepsis as the first possibility. But of course, one should keep the mind open. If the patient, there may be underlying possibility of inborn error of metabolism, or maybe a possibility of some heart disease, there may be possibility of some cholestatic liver disease, some metabolic liver disease compounded by sepsis. Those should always be considered, but still among all the four possibilities, I would still keep sepsis as the first possibility.
So, Bijan, if you want to rule in or rule out of sepsis, what investigation you want to do? If you want to think of hepatitis or cholestasis as one of the possibilities, what investigation you would like to do? And IEM is another possibility of cardiac disease. Are there any baseline investigations we need to do to rule in or rule out each one of them?
So baseline is the differential counts and CBC, hemoglobin, platelet count, all this should be done, and after that we have to do RAT and also by AGOT, AGP, liver function test, and last not but the least, IM should be ruled out because sometimes IM patient may be complicated or precipitated with sepsis. So for IM we can do a lactate, we can do ABG, and in order of merit all these investigations can be done. First to rule out, and also we can do some electrolytes. This is because this may be a case of hypernatremia or hypernatremia.
So I think we need to do three types of investigation. One is to rule out sepsis. We need to do all this. For cholestasis, we need to do liver functions, urine reducing substance because galactosemia can be hypoglycemia over there. There is jaundice. The baby becomes lethargic. He's on breast and formula milk. Urine for fungus. I think because fungus infection can be a smoldering infection. It may take time before the baby collapses, and he had hospitalization risk factors for that. Thyroid is another thing. Whenever baby has prolonged jaundice, we have to rule out because these are treatable causes. IEM plus minus you can wait and do, or you can do at admission at least some baseline investigations. So this baby investigations are like this. Hemoglobin was 16, counts were 17,000, platelets were 72,000, band counts were 12%, CRP was 17 against a normal value of less than 4. Electrolytes were normal. CU. Was there a role for doing urine culture and urine examination in this baby? Yes. So we just said that any baby after 1 week you have to do CU and urine culture. So first sets were 1 to 2 per hyperfilm, bile cell bile pigment were negative, meaning it's not cholestasis. TSP was 5.6, direct was 1.6, but what you can need here is SGOT, SGP are both markedly elevated. So almost more than 4 times. And in this scenario, it can be still an infection, can be still an IEM, still it can be a cholestasis or an IEM presenting with second infection. Is there any role of procalcitonin now?
Procalcitonin has got good sensitivity and sensitivity after 1 week, the late onset sepsis. And it is said that if procalcitonin level is very high, that it can give a good clue for late onset sepsis. I think it can be done at this stage.
So if you have a doubt between IEM, cholestasis, metabolic problems and infection and heart disease, I think this test is useful after 1 week. When you have doubt whether it is infection or not, if this test is negative, then you can say it is not infection. But if this test is positive, the level at cutoff of procalcitonin level, then you can see the more higher the level, the more is going to be the infection and more is going to be the bad prognosis. Even procalcitonin has been used as a prognostic marker in babies with late onset sepsis. So procalcitonin appears to be a good marker when you are clinical dilemma whether it is sepsis or when you have 2 or 3 differences to rule out. This baby thyroid was normal, urine reducing substance was negative, ultrasound abdomen was normal. The CSF also was done in this baby at admission, and this is showing near normal CSF, not much of infection. So the course was the baby was on IV fluids. He has received piptas, that is pupillary centrosubactam fluconazole, and vancomycin, vitamin K and dopamine. The baby improved over the next 48 hours. The baby was started on full feeds. Day 2 he was on feeds, and by day 3 he was on full feeds. The cultures came on the 5th day, which showed Klebsiella sepsis, resistant to pupillary centrosubactam, sensitive to meropenem and cholesterol. Urine culture is sterile. Now, what antibiotic now? Clinically baby has improved, 5 days over, you get the culture after 5 days. Now what should we do? Bijan, you have some idea on that? What antibiotic?
Seeing the clinical condition of the patient and the culture sensitivity, I will go back to I will stop penicillin tazobactam. I will start the sensitive organism what I have, sensitive drug what I have got, because this baby had shock, and also there is culture sensitivity source Klebsiella. Although there may be in vitro resistance, but I think we should not give penicillin tazobactam in this particular patient, rather than we should go with the culture.
Neeraj, you would agree with that? You would agree that you will change antibiotic to meropenem, although clinically baby improved by 5th day?
Actually, it's a difficult situation because on one hand your patient has improved to the piperacillin tazobactam which you are giving, but your sensitivity is different. So one possibility may be that there is a difference in the in vitro and in vivo resistance pattern. So I would tend, since the patient has improved, we have shifted to full feeds, and I would like, one approach is that at this point one can take a new blood culture and send, and then look at the culture report and take a call. Even there is some evidence to suggest a role of doing serial CRPs, though it's not against standard of care, but one can take help of that serial CRP measurements. If the CRPs are decreasing with the same piperacillin tazobactam, then those points is in favor of
Rita, you would agree with that? You want to change or you want to continue the same?
I'd like to change.
So I think difference of opinion is going to be there because clinically baby is improved. Lab is showing that babies cannot improve with this. So, but if you are continuing, there is a role for repeating a blood culture. If you are changing, then you change to meropenem and continue the course. But if you want to change to meropenem, suppose we decided to change for meropenem. Manas, you want to take a 5 days course of peptide into consideration, or you want to eliminate that and continue 14 days of meropenem?
Basically, regarding duration,
Baby is asymptomatic now, 5 days over.
I am still treating the bacteria. So in the new antibiotics, I will give minimum 10 days.
I think at least you can decrease the duration of antibiotic in this condition because in vivo there is sensitivity. Although you change antibiotics, if you want to continue for the total days for 14, 5 days you remove, another 9 days you can give meropenem. Any role of repeat cultures routinely in blood culture positive sepsis? Neeraj, you want to answer? Any role of routine blood cultures? Once you get blood cultures, you have to repeat till it becomes negative, or?
if the patient is clinically improving, then there is no point in repeating the cultures, that should not be done. But if patient is not showing the appropriate response or there is a deterioration, then of course one need to.
So please don't do repeat cultures till you get a negative culture, because if clinically baby is improved, very likely that baby is improved, you don't have to do blood cultures. But any special situation?
The only condition is that when you are talking of fungemias, basically fungal positive blood cultures, there the duration of antibiotics is decided based on once the culture has become sterile. So one need to give at least 14 days of antibiotics, antifungals, once your culture has become sterile. So if your blood culture is showing fungus, in most of the time we are dealing with candida. So you need to repeat it. Once it has become sterile, from that point onwards you have to give at least 14 days. But of course, suppose if you are talking of disseminated candidiasis, then of course the duration is even further longer.
So there is some role of doing a repeat culture in fungal sepsis, because after the fungus has got cleared, you have to continue at least for 14 days or accumulated dose of 21 days. Either one people have taken. But if you are following a short course, then you have to do repeated. You have to repeat the culture till it becomes negative in fungal. Now we have seen that in this case, they have started piperacillin tazobactam, they have started vancomycin and fluconazole. Manas, would you agree such 3 antibiotics should be started? Yes, baby has late onset sepsis is clinically safe, but you want to start 3 antibiotics? Or 2 antibiotics and 1 antifungal?
Basically, it is a very difficult situation because I don't know what is the bacterial profile of the previous unit. So, only thing I will differ in the combination that I could have waited for 1 or 2 days for fungal confirmation before giving antifungals, because that is not going to kill the baby in 1 or 2 days. So I can wait for fungal antifungals for 1 or 2 days, but the primary combination for the antibacterial is quite good.
So you need to cover a gram positive and gram negative. Fungus, you can wait for your cultures or CU and then see if you need to start a fungal. But at least gram positive and gram negative cover is to be given. There is no point in giving 2 or 3 antibiotics which cover only gram negative. Like some people might start cefotaxime, piperacillin tazobactam, or peptides and meropenem. So there is no rule like that. You give 1 gram negative cover, that's sufficient. You give a 1 gram negative, 1 gram positive fever, you may be justified. But no point in giving 2 gram positive cover and 2 gram negative cover. That's not going to help the baby. Now, since we don't have much time, there are new techniques of getting blood cultures early because it took 5 days in this. I'll just summarize because we have only 2 minutes more. So there are new techniques of getting blood cultures early. You know that bacteria can decrease your blood culture from 5 days to 3 days. And if you can get an automated sensitivity pattern, because the biochemical reactions and then you have to do the disc method. If you want to do all this, it will take at least 3 days still. Even with backtech, it will take 3 days. But if you have automated sensitivity testing like this machine, which is really costly, if you have automated blood culture like backtech and automated sensitivity testing, then you can decrease your duration of getting a blood culture with sensitivity pattern by 48 hours. From 5 days to 3 days if you want only backtech. From 3 days to 2 days if you want automatic sensitivity testing. So you can automate entire blood culture by 48 hours, you can finish off everything. Now there are certain new things which I will require Bijon to spend 1 minute on this. Are there any new methods to replace blood cultures? Blood cultures everywhere is a problem. You don't know how to take it properly. There could be problems in technique. Backtech may not be available. Sensitivity may not be done. Microbiologists are not available. Are there any new techniques which are very fast, gives you quick results and helps you to either to prevent antibiotic misuse or to stop the antibiotics?
Yes, sir. There are new techniques. Actually, the problems what we had first is rapid diagnosis. Whether the diagnosis can be made within 1 or 2 hours, so that we can choose the appropriate antibiotic without waiting for 24 or 36 hours. There are techniques, genomic studies, because when the bacteria is in the blood, we can study the bacterial genome, mainly the DNA, or we can see the proteins of bacteria, that is proteomics. You can do genomics or you can do the proteomics. This DNA can be identified because this DNA in the bacteria is universal. The 16 base ribosomal DNA will be available in bacteria only. It is not available in human blood. So if you can take the human blood, WBC as a sample, or you can take the culture media bottle, culture specimen. So what it is done by different techniques, right from fluorescent in situ hybridization to PCR. And PCR you can do the broad-based PCR or multiplex PCR. So our problem is first rapid diagnosis. It is said that if you take the whole blood without waiting for the culture, you can do it within 6 hours. And within 6 hours, what you can do, what are the things, what we have faced during this last 30-40 minutes lecture, whether can we identify the organism. You can identify organism by doing a multiplex PCR. Where you can do, what you can it can be done, you can add 20 to 30 primers, and which is specific to some organisms like E. coli, Klebsiella, etc. So your one job is done, you can identify early. Second job is that you are identifying the bacteria, and that is also very fast. Third point is that, as because nowadays from since morning we are talking about the antibiotic stewardship program and antimicrobial resistance. Whether the resistance strains are available or not. There are techniques where you can see the resistance gene also, and accordingly you can choose your antibiotics. And the fourth and final thing, what has been discussed in this particular case scenario, whether there is a fungus or not. There are fungus probes are available, or we can see the fungus. But these tests are promising, and another, which the tests which are in experimental stage. What I have told, that is about the bacteria in the blood. But there are some host response because of bacterial infection, and that host response, that's like your biomarker, you can see the host response in the human blood, and that is for the signature study. That is under experimental stage.
So what Bijon is saying is, tomorrow or few years later, you will not have any blood cultures done. You will have, you can separate a human DNA, a bacterial DNA can be separated from a human DNA. In the bacteria, based on the genome, you can find out whether it is Klebsiella, Proteus, Pseudomonas, or whatever it is. And if you have Klebsiella, based on the genome of the Klebsiella, you can say whether it is an ESBL or non-ESBL. If it is ESBL, you can also find out that based on the genome, whether it is sensitive to cephalosporin or whether it is sensitive to piperacillin. So people have come to that level. Now, all individuals, whether it is bacteria, virus, fungal, have some specific genome. You have a particular identity on your DNA. And if you know that identity, you can easily be picked up. So this is what is going to happen in future. There is already work in this. People are able to do this, but when it comes in a large scale, it will come everywhere. So I want to say that there is good future. You will know the bug, you will know which bug, you will know whether the bug is going to be sensitive or not, and you will know which antibiotic is going to work for which bug, thereby your antibiotic misuse and overuse of antibiotic is going to dramatically come down. Look at this slide.
This
Safety fast. You can find out everything within 5 hours. You can find out by 8 hours by everything. Sepsis test. By 6 hours you can find out microbe and sensitivity pattern. Magic Plex. By 9 hours, 7 hours you can find out everything. These are culture independent. Once you get a culture, within 24 hours you can grow a microbe. You take the microbe out and then see what microbe it is and sensitivity pattern of that. If you, after the microbe also you can do genetic testing and within 12 hours you can find out. Even when you have do the traditional gram stain or growth of the microbe in the agar plate, from that you can take the microbe and by 12 hours you can find out using genetic test what microbe it is, what is, whether it is sensitive or not, and if it's not sensitive, what is it resistant to, based on the genetic marker which is present in this bacteria. Otherwise, you will continue 5 days or 3 days of antibiotics, empirical, multiple antibiotics for most of the babies who are sick. So we need to find solutions, and promising appears to be molecular diagnosis.
Sir, if you take some blood culture sample, then the yield will be more because there is already growth of bacteria in the culture, and that sample you can get it in 8 hours. As this slide was shown, there is no need of DNA purification. But if you do not take the blood culture, DNA purification takes some time.
So people are looking for these small bottlenecks are still there, but I'm sure day is not long when all of us will depend on this genome of individuals to pick up a disease and also to see whether which medicine works for which disease. So before I end, because treatment is okay, but more important is prevention, and two important methods is prevention of infection and antibiotic stewardship. We'll take 1 point from each of the panelists and then we'll end here. Tell us 1 point on prevention of infection, 1 point on antibiotic stewardship, which you want all of us to do. Vijay, we'll start with you.
First, 1 point of prevention is the hand hygiene.
And hygiene, yes.
And antibiotic stewardship program is that we have to prevention of infection in the NICU and the selection of appropriate antibiotic.
So empiric antibiotics, you need to know your bugs. Neeraj?
One should try to follow all the bundle approach, whether you're putting cannulas, central lines, or antibiotics.
So follow bundle approach for prevention of infection, WAP bundle, ANTT bundle, CLAPSI bundle, yes.
And throughout more of feeding, try to be aggressive on the feeding part. And
Antibiotic stewardship.
in antibiotic stewardship, one should be, when you're starting antibiotics, ask yourself whether this baby actually requires or not. First thing. Once you have taken a decision, please take blood culture before starting antibiotics.
So develop a culture of sending blood culture as well as antibiotic stewardship. Manas, 1 step on prevention of infection. Please don't repeat what others have done.
I will just tell ki avoid IV fluid and give early EBM so that you can avoid most of the sepsis and definitely asepsis as Dr.
So feeding is the most important thing in Indian NICUs. You have to be very aggressive on feeding, whether baby has infection, whether baby has meningitis, whether baby is on ventilation. If there is a chance, feed the baby, get the baby on to early feeds and full feeds. So that is one very important thing which message hand washing and feeding. Antibiotic stewardship.
And secondly, when you start antibiotic, you should have an exit plan.
Good.
Always you should have an exit plan when I will stop, when I can narrow down my antibiotics from the broad spectrum to narrow spectrum.
So when you start, have an end plan. If you start today for a culture positive sepsis, you know that this day I have to stop antibiotics. If the baby is asymptomatic, I stop the antibiotics. Don't do too many tests to be doubly sure, triply sure whether the microbe is there or not. Dr. Lita.
Good housekeeping in the NICUs is very important to prevent infections. And for antibiotic stewardship, collaboration with the microbiology department so that we find out what is the sensitivity pattern and formulate our antibiotic policy for our own unit.
Thank you. So I would end by saying that prevention of infection, one very important intervention is labor room care. We need to go to the labor room and see that the labor rooms improve along with our NICUs. Unless we work on that aspect, we'll continue to face the problem. As far as antibiotic stewardship is concerned, I would say that please stop using CRP for diagnosing sepsis. Please stop using CRP for continuation of antibiotics. Look at the baby. Baby is the mirror for infection. Baby should tell you whether he needs antibiotic or whether you need to stop antibiotics. Thank you.